A 6-year-old gets a needle stick injury from a needle syringe from a hepatitis B positive mother who is a known diabetic and hailing from UP.
पहले मार्क में नीचे कर दिया.
So when the child presents, initially we have to ask the antenatal history. What is the immunization status of the child? Whether the child has received immunoglobulins at birth and the time of presentation to the casualty after the needle prick. I have divided the case according to the scenarios. So scenario 1 is antenatally mother was antenatally positive and child had received immunoglobulins and received vaccination as well. So since the child has received immunoglobulin and routine vaccination and the infectivity of the infectivity with the needle stick injury is around 1 to 6% with the needle stick injury. So we have to check for titers. We can wait and check for titers, and if low, then we have to only give a booster immunization, and if high, nothing more to be done. The child is already protected from protected. Scenario 2 is antenatally mother was positive and the child was unimmunized. The child did not receive immunizations. Since the child, we have taken into account the child, the mother is from UP, the vaccination status might not be good. So at presentation, the most important at that time is immunization. Since we are assuming that on the history the child has not been immunized, so immunize the child immediately. And if the mother is, they are affording and they then give immunoglobulins. Immunoglobulins have to be given within 24 hours. If not, then we can, the maximum time is around 14 days. After 14 days, you do not give immunoglobulins. But the primary aim is to start immunization as soon as the child has presented. And since the child has been unimmunized, mother was antenatal positive, we have to check for the status of the child, get the mother's titers done, and the E antigen of the mother. E antigen is because if the mother is E positive and HBe positive, the seropositivity is more and the transmission risk is more if the mother is antigen positive. Scenario 3, the mother received postnatally acquired HBV and the child presented within 48 hours of the injury. Since again we are considering the mother is from UP, will not present initially, will present after 4-5 days. So the child is presenting within 48 hours, so immunization has to be given at the time of presentation, assuming the child has not received immunizations. If the child has received immunizations, then only the booster has to be given at that time, and immunoglobulin has to be given at, if the mother is affording. And now the scenario 4 is child has presented after a few days. And again, the primary aim is to immunize the child. As soon as the child presents, you have to start the immunization schedule 0, 1, 2, and 6. And after that, immunoglobulin role is there, but initially if the child comes, the best time to give immunoglobulins is within 24 to 48 hours. And the maximum limit is around 14 days. But after 14 days, there is no role of immunoglobulins. And at that time also, they have to get the mother's titers done and the viral load done. So the take-home message is vaccination is a must. Vaccination as soon as the child presents after a needle stick injury, mother is HB positive, we don't know the vaccination status, we have to give the vaccination as soon as the child comes. If possible, then you have to give immunoglobulins. If not, then vaccination is to be given. The timing of presentation and the vaccination for every child. Routine vaccination has to be given because if the child has been vaccinated according to the immunization schedule, so there is a 90% efficacy that can be achieved only with vaccination, and the risk of transmission decreases.
You have kind of immunized the child and all. Are we? Do we stop at that, or do we do something beyond that? Kind of, yeah. That's what. Do we kind of monitor for whether the child has responded to the vaccination, whether the child has become HBs positive at a later date? If yes, when? If no, why not?
Child has presented, we started the immunization after first or second dose. After 2 to 3 months, then we can do the titers to see if the child is responding or not.
Actually, in such a case, at first point of presentation, you will send the anti-HBs titers because that will make matters very clear how to proceed further.
I think if the child has not been vaccinated at all or has, often it is an incomplete vaccination, that is when titers will be important. And you didn't mention the titers you're looking. What is a high and a low titer?
The titers are less than 10,
Yeah.
so it's a non-responder, or if the titers are more than 10, it's a responder.
So you need a titer more than 10 in a person who is not immune compromised. In a patient who is immune compromised, you need more than 100. So that is an important, what titers you need. And the reason we put up UP was because people feel that there is, Dr. Yacha and Dr. Thapa, please correct me if I'm wrong, that there is universal immunization available in all states across the country. It is not. As far as I know, only 17 states have universal immunization for hepatitis B. UP, Bihar do not have that. So in all likelihood, this child has not been vaccinated as part of the immunization program.
Non-BJP government.
इसमें साधारण क्वेश्चन है कि I will ask you a simple question. ये सारी छोड़ो scenario 1, scenario 2, scenario 3. Doctor is sitting, सर ये लग गया hepatitis B mother को आज उसका सिटिक लग गया. अब क्या करें? What is the first step? To this child, you don't know anti-HBs will take 1 week to come. You have to go laboratory, this thing, that thing.
We vaccinate the child at the time of presentation. We have to give the vaccination, start the vaccination.
John, you wanted to say something? What would you do? What is your consensus on this point? As practitioners, what would you do? Pardon? Immunize. Would you like to give HBIG, hepatitis B immunoglobulin? Yes or no? Yes? Correct. So you give, you don't know. See, you don't know the status of that patient. HBIG क्या है? मेरे हिसाब से, my own thinking is, we'll do HBIG दे देंगे उसको, because what is the incubation period of hepatitis B? Today I got a virus into my this. What is the incubation period when it will have the manifestation?
6 months.
तो जोर से बोलो.
6 months.
हैं?
6 months.
6 weeks to 6 months. So, वो याद रखना है. 6 weeks to 6 months. Even if somebody tells the HBsAg status in this child, you will not get anything if he is already negative, because this will take 6 weeks to actually have the infection. So you will give HBIG quickly, you will give immunization as rightly pointed out by them. बाद में बाकी बातें करेंगे, इसको वैक्सीन लगा था नहीं लगा था वो सब पूछेंगे बाद में. And even if he has received the vaccine,
Booster.
there is nothing wrong in giving one more dose of hepatitis B vaccine in this patient. That is the story here, I think. क्यों सर डॉक्टर साहब?
Yeah, I agree with you. Because if you give just vaccine and you don't cover this period of 6 weeks or so, the antibodies are not going to be produced in the body per se to that antigen. So therefore you have to cover with the IBIG followed by vaccine at the same time.
Any variation, sir? Dr. John? Mike.
Essentially, if you look at the Western books and the recommendations, they tell you don't do anything much. But that is because most of their patients have a documented seroconversion evidence. They've given the vaccine, checked the antibody titers, found it is more than 100. They have seroconverted, it's fine. In 99.9% of our patients, either they are completely vaccinated but not, we don't know whether they are seroconverted. Please remember that hepatitis B vaccine seroconversion is not 100%. It depends on the age. If you give it in the newborn period, it may be 98. As the child grows older, seroconversion rates come down. So vaccination is not equal to seroconversion. We can't assume that. Right? So Western recommendations need to be taken with a pinch of salt, because in most of our situations, it's never a documented seroconversion. I'm sure all of you would have had hepatitis B vaccine. But it's likely that, considering our average age must be 30 or 40, at least 30% of us have not seroconverted. The older you are when you vaccinate, the less is the rate of seroconversion.
Absolutely. The one more scene is there. See, there is a scenario. If somebody as a medical professional gets this stick, then that role, hepatitis B, HBIG, everything you do. Now here is a child who is living in the family with the mother, who is hepatitis B positive. The chances are that already either horizontal or vertical transmission to this child has already taken place. Therefore, I would think, I would take a blood sample keep it before I give actually hepatitis B immunoglobulin and HB immunoglobulin. I will keep it with me in my cold storage and then test it. At that time, I will give the vaccine HBIG, but keep this whether he is already HBsAg positive from the beginning or not. Otherwise, what they will say, there are people, they will say, sir, इन्होंने hepatitis B का injection लगा दिया, इसी बाद में आएगा. मैंने तो लगाया था, वो already positive था. They will put an allegation on you. इसी दवाई से hepatitis B हो गया. याद रखो. सारा ठीक नहीं, injection से हो. तो इसलिए हम एक सैंपल निकाल के रखेंगे where there is a question of mother, father, somebody stick within the family. Keep the sample, test it, which will not cost you much, and give the vaccine and HBIG at the same time.
So just one query, just what sir said just now.
Yeah.
Like he said 30% of the the audience sitting out here may not be seroconverted, and they all are into medical professions. So would you recommend doing titers in all of them?
You should, always. Medical professionals should test their titers.
All high-risk people, that includes doctors, dentists, should be checked for seroconversion. And if you haven't seroconverted, repeat the entire 3 doses. And you will find that at the end, there will still be a 10% who don't seroconvert whatever happens. And they are the ones who are never going to seroconvert. Dr. Jacob John is one of those. Yeah, he has taken 6 doses and never seroconverted. So basically, we need to prove, this is a catch there. In all Western recommendations, this will tell you seroconverted, therefore don't do anything. Just leave it alone.
No,
regarding immunization, this is a common problem faced by some of the pediatricians like me who are in practice. The baby has delivered in a medical college. There, some of the colleges do not offer hepatitis B at birth. And it's likely most of these babies are brought at 3rd or 4th week to either us or to some institute there. They happen to take the first dose sometimes at around 1.5 months, second dose at 2.5 months. Some people still follow giving the third dose at 3.5 months rather than 6 months. Is there a study to tell us whether a differentiation in the response is better with 1.5, 2.5 and 6 or 1.5, 2.5 and 3.5? I'm not talking about 0, 1, 2 and 6. This is a peculiar problem because most of these babies have delivered in an institute which is a government institute where immunization is still not being offered at birth.
Yeah. I think the recommendation between seroconversion between at birth and 1.5 months is not very significantly different. We are recommending vaccine at birth to prevent vertical transmission. Unfortunately, a few years ago in one of the IAP's recommendation itself, they were trying to involve a vaccine schedule. It was taken out and, they said 6, 10, 14 weeks you give that combined vaccine which gives hepatitis B. That's a wrong recommendation because in this country, the commonest mode of transmission of hepatitis B is at birth, right? And there are 2 schedules you can follow. The critical factor is the interval between the first 2 doses. That means you give a 0, 1, and then that 6 or whatever it you give is a booster dose. So that even if it comes at 8 months, of course you shout at the patient saying, why are you coming late? But there's no harm, you just give it and the schedule is over. But if the interval between the 0 and 1 is more than 2 months, then there is a problem with primary seroconversion. So in that case, if you think it's significantly long, you give another 2 doses. So the crucial factor is the interval between the dose 1 and 2, not between 2 and 3. And if you have a patient who you are giving at, say for example, a baby born to a mother who's hepatitis B positive, it is 0, 1 and 3 because it's a rapid seroconversion, but in which case you have to give a booster at 12 months. So 0, 1, 6 or 0, 1, 3, 12. 2 or 3, doesn't really matter. But it's 12. That booster is often forgotten. Actually, we looked at it, in my own hospital, we looked at this. The default rate of the 3rd dose is extremely high. That 0, yeah, I think they will be very large. Even us as doctors would have defaulted. 0, 1 and 6. So that 6th one in our setup, I think is, the default rate is extremely high. They take the 2 and then don't come back. But in which case, whenever you get them, you give a dose, it will act as a booster.
What about...
Yeah. Just follow the same schedule, 1.5, 2.5, and no problem at all. There's no hurry.
Just one point to re-emphasize. When you have a high-risk group, always test the others before you vaccinate. So this child, if he has siblings, the sib should be tested before you give them the vaccine. Same for the father. The father should be tested before you give them the vaccine. As he said, they may be already positive. And then you're vaccinating them, they come back with cirrhosis so many years later and they said, we got the vaccine, however we got the cirrhosis. So in any high-risk group, when you want to vaccinate them, first test. It's not a universal advice, but in the high-risk group, first test and then vaccinate.
This presentation, they have mentioned 4 doses of hepatitis B. Just elaborate on that.
What is the question?
0, 1, 2 and 6 has been mentioned. 4 doses have been mentioned in this presentation.
4 doses. When 4 doses?
0, 1, 2, 6 was mentioned in this
No, when 4 doses are recommended actually. That's
when
what
are 4 doses recommended?
0, 1, 3 and 12.
In the presentation it was 0, 1, 2, 6. Here.
Low birth weight babies. Low birth weight babies have to be given 4 doses.
Seroconversion is only when there is a risk of hepatitis B. But your seroconversion is over with your first and second dose. So your third and fourth is only for boosting effect.
Babies less than
Do you recommend that we give it at
1,600 grams have to be given 4 doses.
Seroconversion is poor when the baby is below 1,500.
Then even you recommend a booster after this also at 1 year?
If it's a third,
So this case is not a premature baby anyways.
She's pointing to this case. Why have you mentioned 4 doses?
So 6, this case.
Current
Child is
scenario.
not immunized, so we are giving 0 at that time.
we go on to the next.